Okay. Oh, there we go. Across the country, many communities are implementing new approaches to public safety, which reduce reliance on police for folks experiencing mental and behavioral health crises. Communities are addressing these as a public health issue, not a criminal issue, and they are matching a health-first and care-centered response to a behavioral health need. We're going to briefly describe what happens now in most communities, and then we're going to take you on a road trip across the U.S. to see some cities that have added a different kind of response to their wheelhouse, a response that is more effective, doesn't leave a trail of trauma, and is also less costly. But don't worry, our road trip's only going to take about 20 minutes, and we promise at the end of the journey, you're going to feel hopeful. We're going to share our slides, script, and a slew of footnotes and links afterwards, so don't worry too much about taking notes. Here we go. First up, some statistics.
Hang on, Sally. Sally, hang on. I don't know why. Interesting. Okay. Go ahead.
Ready? Okay. First up, some statistics. A quarter of adults and a third of young people currently have a mental illness. Nearly half of young adults have either a substance use disorder or a mental illness. And here in King County, among young people, suicide is now the second leading cause of death. When we hear about police responding to a behavioral health crisis, we often think of houseless people in distress in public. And this breaks our hearts, and it can also feel scary. Most of us are not experts, and most of us don't have the right skills to help. However, it's important to remember that crises happen in all kinds of places at all kinds of times, including homes, schools, and offices. This quote from an Orange County community responder highlights that community responder teams are for everyone. From San Diego County's community responder team found out that most of those helped have been housed individuals experiencing a crisis. Only about, and this is kind of surprising, but only about 18% of clients served to date have been people experiencing homelessness. Now we're going to share two stories. And as we do, we want to encourage you to think about people you know or love or meet in your everyday life. Some you are close to, some are acquaintances, and many you randomly encounter as you go about your day. Mental and behavioral health problems can affect any of these people. These issues can be frightening and confusing for the people involved in the problem, the people around them, and the people who love them. We want to share two stories based on real people in King County, though we've changed some details to protect privacy. First up is a story about a teen with depression. The teacher of a high school freshman receives an email one Saturday from a student with what they think are concerning and alarming suggestions of suicide. It's late September and a Saturday, and the teacher doesn't have contact information for the family. The email feels urgent, so the teacher calls 911. What happens next? We'll come back to this scenario, but we encourage you to think about this teen and their family as we go through the presentation. Here's another scenario. The owner of a small convenience store greets a regular customer who comes in agitated and doesn't respond when talked to. Other customers appear uncomfortable and start leaving. As things seem to get worse, all the owner can think to do is call 911. The police come, handcuff their customer, and take them away, which the owner and the few customers in the store find quite distressing. Could there have been a better option than dispatching police?
When someone calls 911, in most communities, the dispatcher has only three options. Fires or medical emergencies are pretty obvious. All other calls, including behavioral health crises, are dispatched to police. And yet, a behavioral health crisis is not a crime. It is an emergency, which requires a response with the same quality and consistency as a response to a heart attack, stroke, and other health emergency. We've gone from asking the police to be part of the solution to being the only solution for problems they should not have been asked to solve in the first place. As the Dallas police chief said, We're asking cops to do too much in this country. We are. Every societal failure, we put it off on them to solve. Not enough mental health funding? Let them handle it. Here in Dallas, we got a loose dog problem. Let's have them chase loose dogs. That's too much to ask. Policing was never meant to solve all those problems. People think most 911 calls are because of a cardiac arrest or a violent incident. That is a misconception. The majority of 911 calls don't involve medical issues, violence, or threatening incidents. We often say that people call the police, but in truth, they call the number we gave them for emergencies, and then we send the police. People who are scared or worried call 911 to ask for help because they don't know where else to turn. National studies analyzing police call data show that between 19 and 38% of 911 calls don't require a response from armed police. This includes behavioral health crises, among other kinds of calls for help. Another recent study of 9 cities, including Seattle, showed that fewer than 3% of calls were for situations involving a violent crime. Just a few weeks ago, the Los Angeles Police Union released a list of 28 calls for service that they believe can be handled by responders who are unarmed. These range from landlord-tenant disputes to loud noise or party calls to non-criminal mental health calls. A police union director said, police officers are not psychologists, we are not psychiatrists, we are not mental health experts. We are not social workers, doctors, nurses, or even waste management experts. Many people think we should be all those things, but we are not. We should be focused on responding to emergencies, saving lives and property, and of course, engaging in community policing. Dispatching armed officers to calls where their presence is unnecessary is more than just an ineffective use of resources. It can also cause harm, especially to groups who have been disproportionately impacted by the criminal legal system, like communities of color and individuals with physical and intellectual disabilities, including autism. Even the best intentioned and well-trained officers arrive in patrol cars, sometimes with lights and sirens, with a badge on their chest, handcuffs on their hip, armed with guns and tasers, and with the possibility of fines and incarceration.
Back to the true story of the student whose teacher called 911. Here's what happened. The police arrived and knocked on the door. The officer told the alarmed parents what was happening and stepped inside. The student learned that their teacher had, in their words, called the police on me. Though the police did not have their sirens on, a classmate out mowing his lawn saw them arrive, and as a result, the high school rumor mill took off. For months afterward, neighbor after neighbor asked why the police were there. Let this sink in for a minute. Unlike many situations when someone is in a crisis, no one ended up being arrested, hurt, or killed. The officer was kind, and the student wasn't detained or physically hurt, but their relationship with the teacher and school in general was gravely harmed. This student could barely stand returning to school, feeling deeply embarrassed and unable to shake the feeling of betrayal by the teacher they had confided in. But what other options did the teacher have? As we share examples of community responder teams, think about what that kind of response could have looked like for our teen and their family, and the shop owner and his customer. For people experiencing behavioral health crisis, an armed police response presents staggering risk. A quarter of police shooting deaths are linked to mental health crises, and half of those shootings occurred in the person's own home. So what does a better response look like? Prior to the development of our emergency medical system in the late 1960s, it was common for police officers to transport sick or injured people to the hospital in their patrol cars. This was obviously not ideal, as police officers often lacked the specialized medical training to provide appropriate care to patients. Over the last 50 years, EMTs and paramedics have become the primary first responders to medical emergencies, and we now get a medical response to a medical emergency when we call 911. This demonstrates what's possible. Local governments can establish a new emergency response that provides a better answer to specific emergency calls for service. A new emergency response model specifically designed to address behavioral crises is emerging in many cities and counties. Community responder programs are being created for reasons similar to the establishment of paramedics 50 years ago, to send highly trained responders with the appropriate skills and expertise to effectively manage crises. It's all about sending the right people at the right time with the right skills to effectively address the needs of each emergency call. Let's start by defining some terms. There's no universal agreement on these definitions. Here's how we use them. Right now, aside from traditional police response, the most common response to behavioral health crisis are co-responder teams. Co-responder teams typically include an armed police officer and a behavioral health professional who respond together to crisis calls. We use the term embedded co-responder when referring to a police officer and a behavioral health professional who ride in the same police vehicle. The co-responder model assumes people in a behavioral health crisis are dangerous, and all these situations require an armed law enforcement officer. They are not focused on reducing police presence, just augmenting it with the behavioral health professional. The term mobile crisis teams most often refers to non-police teams that are dispatched through crisis lines and 988, not dispatched through 911. Community responder programs are non-police teams generally made up of one or more behavioral health specialists with training, experience, and expertise in crisis intervention and de-escalation. They are directly dispatched by 911 dispatchers, just like other first responders. They are often on police radio so they can call for assistance, and they can self-dispatch, meaning they hear all the 911 calls and can respond to calls that are within their expertise. Community responders offer voluntary services to community members and don't enforce laws. The care provided may be as simple yet as important as listening with patience and compassion, buying someone a chicken sandwich, or helping get a prescription refilled. Quite frequently, the client will be connected to other resources. Community responder teams usually have at least 2 team members, both to include a range of skills, and because teams of 2 add a layer of safety. Here are the possible roles. A behavioral health specialist could be someone with a bachelor's or a master's in social work. It's important to underscore that no one is being clinically diagnosed by community responder teams. A crisis worker is someone trained in crisis response, but without the social work degree. These individuals might have personal insight about the communities they work in. For example, one team in St. Petersburg, Florida, counts a former pizza delivery driver as one of their best navigators. A peer support specialist is a person who has lived experience with mental illness, substance use disorder, homelessness, or another behavioral health-related issue, and has been trained as a specialist. Olympia, Washington has an amazing program with peers and formerly incarcerated people doing the outreach work. A healthcare provider can be an EMT, a paramedic, or a nurse. Dayton, Ohio has an innovative program using mediators who respond to calls, including issues like noise complaints, disputes among roommates, and loitering. Although the kinds of calls that community responders are sent to are largely behavioral health related, communities are finding that their responder teams are often highly effective at responding to a much wider range of calls that do not require police response.
Indivisible Eastside has created a directory of more than 90 community responder programs across the country. The details vary across cities and counties, but all these programs have unarmed non-police response teams, and they can be dispatched through 911. So let's go on a road trip. We'll start in Eugene, Oregon with Cahoots. For more than 30 years, Eugene has been home to crisis assistance helping out on the street, or Cahoots. If you dial 911 because your mother or son is having a mental health or drug-related episode, the call is likely dispatched to Cahoots, whose staff is trained in crisis intervention and de-escalation. Cahoots is operated by a community health clinic and funded through the police department. The program sends 2-person teams consisting of a medic and a crisis worker. Everyone completes extensive training guided by an experienced mentor. Importantly, they are not required to have advanced degrees. Cahoots responds to more than 22,000 calls every year. Calls come to Eugene's 911 system or to the police non-emergency number. Dispatchers are trained to recognize nonviolent situations with a behavioral health component and send those calls to Cahoots teams. Cahoots staff carry police radio, can self-dispatch to calls. The Cahoots teams have called for police backup only about 300 out of those more than 22,000 calls. A Cahoots outreach worker explains why this is the case. The tools that I carry in my training I carry my de-escalation training, my crisis training, and a knowledge of our local resources and how to appropriately apply them. I don't have any weapons, and I've never found that I needed them. The success of Cahoots has encouraged other communities across the country, including Denver, Oakland, Olympia, and New York, to develop similar community responder programs of their own. So let's look at Denver's program. Modeled after Cahoots, Denver's Support Team Assisted Response Program, or STAR, began in June 2020 with two-person teams of a paramedic and a mental health clinician. A deep analysis of STAR data by Stanford University found a 34% drop in low-level crimes reported in precincts where STAR was operated in the first 6 months of the program, compared to precincts where the program didn't have any presence. The study also found dramatically lower costs. The researchers calculated that the cost of STAR was 1/4 the cost of a typical law enforcement response. Since the pilot began in 2020, STAR has responded to thousands of calls for service that would have been otherwise dispatched to police. There has never been a need to ask for police backup due to safety concerns. The pilot has been so successful that Denver just funded a citywide expansion. Now let's talk about the HEART program in Durham. The Holistic Empathic Assistance Response Team, or HEART, launched last year in Durham, North Carolina, and includes 3 layers of response. They embed mental health clinicians in Durham's 911 call center to handle some situations over the phone. The Crisis Response Team is a 3-person team of non-police first responders who are dispatched to nonviolent behavioral health and quality of life calls for service. And Care Navigators follow up with people within 48 hours to help connect them to community-based care. Let's pause here and remember our earlier story about the student. What would it have looked like if the response to her worried teacher's call had been a community responder team? What about our business owner? Could a team have navigated their customer to other kinds of care?
Now we're zooming all the way across the country back here to King County, and we have some exciting news to share. First up, we're going to talk about RACER, Regional Crisis Response. The cities of Bothell, Kenmore, Kirkland, Lake Forest Park, and Shoreline, I know, kind of strange bedfellows, have recently signed an agreement to jointly staff an unarmed community responder program. These 5 cities had previously had an embedded co-response program where a police officer and a social worker were in the same vehicle. However, they now have a new agreement in which they have replaced that program with RACER. And instead of reporting to police chiefs, they're reporting to the city manager's office. They are in unmarked vehicles, not police vehicles. And while they are not yet directly dispatched from 911, we had some good news and a good meeting last week, and we think that's coming up soon. So we're excited about that. And now in Seattle, we want to highlight Health One. We think those of you in this health meetup might be particularly interested in this program. It's a program of the Seattle Fire Department. They pair a social worker with a firefighter. Fire department programs have the advantage of being able to address both physical and mental health needs, which, as you all know, are often intertwined. As well, fire departments have physical stations all across the community, and they can use lights and sirens to respond quickly if needed. Also, because they are a health program within the fire department, their teams are allowed access to a client's medical history, such as recent hospitalizations and prescribed medications. That information is not available to police responders without several additional calls. Again, as folks in a health meetup, you can likely appreciate how having this information can be very valuable to responders. Health One's unofficial mascot is a sloth. I have a little stuffed one here, because their teams slow everything down. Traditional police and fire response is geared toward respond, clear call next, respond, clear call next. And that emphasis on speed is the antithesis of what is needed for behavioral health crisis work. As you can see, we have promising programs in our region. We just need to get more of them. Now let's talk about safety. Let's start by noting that just because someone exhibits behavior outside of societal norms does not mean that the person poses a threat. As a Vancouver police officer stated, there's a big difference between being uncomfortable and being unsafe. There are many myths about mental health and violence. However, research shows people with behavioral health conditions are rarely violent. Only about 4% of violent crime is committed by people with mental illnesses. In fact, people with mental illness are 10 times more likely to be the victims than to commit violent crimes. A recent study found that 84% of behavioral health related 911 calls did not involve any violent behavior or weapons. And 911 dispatchers always ask about weapons and will include a police response if they are present. While the safety of responders is a valid question, it's equally important to remember that these community responders are professionals who have received specialized training in crisis intervention and de-escalation techniques. And they took these jobs because they want to do this work. As well, across the board, community responders report that their teams are safe. In fact, we have 33 years of data from the Eugene program called CAHOOTS. Only 1.4% of the time did they call police for backup. You heard that statistic earlier, but wanted to re-emphasize it. 1.4% of the time do they call for backup. Those results are actually confirmed by a recent study of 23,500 calls across 7 different cities where unarmed community responders were dispatched. In Santa Fe, the Alternative Response Unit, or ARU team, quickly learned that they don't need police to respond safely. And to us, this is a really exciting story. ARU was originally composed of 3 responders, a paramedic, a case manager, and a uniformed police officer. But within 8 months of launching the program, the unit slimmed down to a team of 2, a case manager and an EMT, but not a police officer. They safely responded to incidents without a police presence and focused on outreach and de-escalation. And again, like all teams who are on police radio, they can always ask for police backup. The fire department's program manager explained, since the majority of calls that the unit responds to came through 911, having an officer to navigate those systems helped at first. But when police officers were part of the response, fully equipped with a gun, pepper spray, and other weapons, their presence cast a shadow over interactions with the public. Conversations about safety don't usually center the person in crisis. Let's not forget that they deserve to be safe too. In fact, that's one of the primary benefits of community responder programs.
Let's talk about those benefits of community responder programs. First of all, they are care and person-centered, which create better and longer-term outcomes for the clients. They provide specialized care and support and align healthcare response with a healthcare need. They provide immediate crisis stabilization of both urgent mental health and medical needs. They connect individuals in crisis with the resources they need to address underlying issues and can help individuals receive ongoing care and support. They reduce the trauma and stigma of police involvement. No sirens, firearms, handcuffs, or threats of arrest. Many clients' issues are resolved in their own homes without requiring transport to the emergency department for mental health care. They divert people from the legal system and legal costs. Fewer folks are sent to jail or end up in court. Community responder programs also increase public safety. Police officers often spend a significant amount of time responding to calls that are not related to criminal activity, such as mental health crises and homelessness. By diverting calls to community responder teams, police can focus on responding to, investigating, and solving violent crime and other emergencies that may require an armed response, which is especially relevant when so many departments are having staffing issues. The Durham police chief said, the community responder team gives time back to all of our team to be able to patrol where they are most needed, to be able to respond to those violent calls that we are seeing an increase in, as well as just being able to focus on maybe some of the other proactive measures that they've wanted to do. She mentioned one officer who told her he'd recently been able to find time to gather video recordings, which was crucial evidence in a property crime case that he was working on. Community responders lower the pressure on overcrowded jails and overworked courts. And as we saw in the Denver Star analysis, community responder programs can reduce crime. Community responder programs are fiscally responsible. They have the potential to save costs in several areas by providing appropriate care and support to people in crisis. Denver Star data found the direct costs of having police as the first responders to individuals in behavioral health crisis are more than 4 times higher than with a community responder model. There are savings when ambulances and emergency medical services aren't needed. And there are savings from reduced ER visits because community responders can address so many things in the field, thus preventing many expensive and non-therapeutic visits. Community responder programs can avert unnecessary arrests and detentions, which reduce legal costs, including court costs, incarceration costs, and other related expenses. And finally, community responder programs are very popular with the public. Recent national polling shows that voters overwhelmingly support creating a new agency of first responders who are better suited to respond to mental health and homelessness-related situations than armed police officers. For individuals facing behavioral health emergencies, equitable treatment with dignity and compassion should be provided without fear of criminalization. Community responder programs provide specialized care and support, ensuring that people in crisis receive an appropriate, care-centered response that meets their needs. We're happy to provide our sources, and there's a lot of them. Thank you very much. And now we'll try to answer any questions you have.
Thank you very much, all of you. This was wonderful, Ruth, Heather, and Sally. This was a lot of information, and I'm going to pause the recording now, and we'll continue our conversation. Thanks again.